Alright guys, it's Dr. Muhammad. This is going to be the last video in our ethics section. So far, we've talked about ethical principles, the things that you need to consider before you even begin talking to patients. We've talked about how to determine if a patient has decision-making capacity, how to get informed consent from a patient, and now we're going to move on to talk about caring for patients, the directives for caring for them, and how we are going to make medical decisions. And the first thing that we need to talk about here is going to be advanced directives. Advanced directives is basically instructions that are given by the patient themselves for future medical decision making. Examples of this include something like a DNR, a do not resuscitate, a do not intubate, which is a DNI, or comfort measures only, which is CMO. And these are things that you may have heard in the hospital. They're commonly called code status, that we refer to patients, the care that they want to have done. Just as a side note, comfort measures only is one that some people may not be familiar with, so I just wanted to touch on that briefly. Basically, what comfort measures only is we are withdrawing all active care from a patient, and essentially we are allowing them to pass away, to die. The important thing to note about CMO, comfort measures only, is that it's allowing patients to die passively. It is not an active process. It is not the same thing as a physician-assisted suicide. It is just trying to withdraw life-saving treatment and focusing more on patient comfort and relieving pain. I just wanted to touch on that quickly, but all of those, DNR, DNI, CMO, these are all examples of advanced directives. These are the things that the patient wants done or does not want done with regards to their care. An important thing to know about advanced directives is that they may be oral or they may be written. An example of oral advanced directives is something as simple as a family member having a conversation with their loved ones. If something were to happen to me, this is what I would want, this is what I wouldn't want. It doesn't have to be any formal conversation in any formal setting. It can just be a sit-down conversation at the dinner table. That is an example of an oral advanced directive. On the other hand, an example of a written advanced directive is a document with specific interventions regarding potential treatments or illnesses. So if I become critically ill and I need to have a breathing tube put down my throat, I do not want that. That is on a document. It is signed by the patient. An example of that, as we see here, is a living will. So it clearly delineates that if these things happen, this is what I do want done, this is what I do not want done. But both of those, whether they're oral or whether they're written down, are examples of advanced directives. And if a patient has that, we need to honor that. If a family member comes in and says, my dad, my husband doesn't want CPR, they don't want someone pushing on their chest to restart their heart, we have to honor that, and then we would cease resuscitation at that time. An important thing to know about advanced directives is that most states do actually have a legal document that kind of clearly breaks all of these things down. Probably don't need to know this for the exam, but an example of this is what's called a MOLST. This stands for a Medical Order for Life-Sustaining Treatment, MOLST. That is one of the most common ones that I've seen. There is also another one called a POLST, which is a POLST, that stands for Physician Orders for Life-Sustaining Treatment. So that's one that's filled out by a physician. That's probably not too high yield for the exam, but I do want you to know those acronyms, MOLST and POLST, just in case that does come up, because there are documents that cover that. In addition to these advanced directives, a patient may have something called a power of attorney. So what's a power of attorney? Power of attorney is when a patient designates a certain individual to make medical decisions for them if they do not want to or if they become incapacitated. And those are really two important distinctions to be made there. As I've said in previous videos, some patients just don't want to make their own medical decisions. They would rather have their spouse do it or their oldest child do it. So they may designate someone to do that as power of attorney. Conversely, if a patient becomes incapacitated, they may have someone designated as their power of attorney in case they become critically ill. The really important thing to know here, however, is that this can be revoked if a patient has decision-making capacity. I don't know if they would necessarily give an example on the exam. It might get a little bit complex, but just know, for example, if a man designates his wife as power of attorney, but he has decision-making capacity and he is saying something different than what the wife wants, you would have to respect the patient's wishes. The patient still has autonomy, they have decision-making capacity. Even though this power of attorney issue is there, we need to respect the patient's wishes at that time. And because of that little caveat, this is something that's more flexible than a living will. It can change, it is fluid, and there can be changes that happen. The next thing that we need to discuss here is a surrogate decision maker. Now, a surrogate decision maker is a medical decision maker if the patient loses decision-making capacity or if they do not have an advance directive. So we don't live in a perfect system. People aren't always having conversations about their wishes. They aren't always having documentation or power of attorney or those kinds of things. That's where a surrogate decision maker comes in. And this is how we determine who is able to make decisions for the patient. And this part here is really high yield. So we got to take very special note to this. There is a legal priority as to who is going to become the surrogate decision maker for the patient. First on the list is going to be the spouse. If the patient has a significant other, that person becomes the surrogate decision maker and they will make the decisions. If there is no spouse or if they are not available, then it would be the adult children who would be able to be the surrogate decision maker. If for some reason adult children are not available, it would be the patient's parents. If the parents aren't available, it would be the patient's adult siblings. And if for some reason you can't get in contact with any of those people, if there is any other relative that you can find related to the patient, that person would become the surrogate decision maker. This is so important. They will potentially give you a question on the exam that there's a patient who is critically ill and the wife wants to do one thing, but the patient's oldest son wants to do another thing, and who gets the final say? You need to know this information. Based on that example, the priority goes to the spouse, to the wife. So that is a person who is the surrogate decision maker and would be making medical decisions for the patient. Super important. I cannot stress that enough. And an example of a surrogate decision maker, in addition to that, is if a patient's on a ventilator and the spouse wants to withdraw care. Going back to that same example, if the spouse sees their loved one, they say they wouldn't want this, I want the ventilator to be discontinued. As that surrogate decision maker, we have to respect that decision and do what they would like us to do. To go along with that, the last thing we're going to talk about here is ventilator assisted life support. And again, in an ideal world, this is something that should be talked about before it happens because this is a big deal, but that doesn't always happen. Okay, so a discussion would be nice, but it's not always going to happen. Because of that, any decisions regarding ventilator care need to rely on the surrogate decision maker, the prognosis of the patient, and the patient's wishes. And this is a really complex thing. This is going to involve multiple different specialties. This is going to involve social services, chaplain services, family services, all of these different things to make sure that we are doing right by the patient and also to make sure that we are doing what the family, what the surrogate decision maker would want. If, for example, a surrogate says that the patient would not want to be on a ventilator, then as the surrogate decision maker, we respect that and we would withdraw or withhold care. However, if we are doing that, if we are going to withdraw or withhold care, like I said, this is going to involve palliative care. This is going to involve religious leaders. We would need to inform the primary care physician in the event that the patient unfortunately passes away. This is a very complex process, and that's why things like having a surrogate decision maker, having a living will, having the MOLST form are set up to help make the process easier, because in these really tense moments, it is hard to make those decisions. And we as a physician need to know what the order of operations is here as to how we can help our patient. Quick recap before we wrap up here. Advanced directives, remember, these could be oral or written. It could be something as simple as a conversation about what a family member would want at the dinner table, or it could be something more complex like a living will. An example of that is a MOLST form, a medical order of life-sustaining treatment. Power of attorney is if a patient designates someone to make medical decisions for them or if they become incapacitated. Remember, this is something that can be revoked if the patient has decision-making capacity. A surrogate decision maker is someone who makes medical decisions for the patient if they lose decision-making capacity or if they do not have an advance directive. Really important to know the order. It'll start with a spouse, then it'll be the adult children who make the decisions, then the parents, then the adult siblings, and then any other relatives. Finally, ventilator-assisted life support is a complex system. It's going to require multiple people, multiple specialties. We're going to need to involve the family and the surrogate decision makers and do right by the patient. With that being said, that is going to be the end of the ethics section, and I will see you in the next video.